Good morning, everyone. Thank you for joining us. It is the Family Support Planning Council's statewide meeting. It's our quarterly statewide. And I'm Iannuzzelli, and I'm the chair of the Family Support Planning Councils at the statewide level. We have 10 councils representing families of people with intellectual and developmental disabilities throughout the state of New Jersey. And our mission is to advocate, support, empower, and educate families. And we share our experiences, and that is what we are all about. So for today's meeting, we are focusing on health and wellness, and we have some wonderful speakers that are joining us. And they are all council members as well, which is really a great thing. So first, I'd like to introduce Andie Iannuzzelli. And Andie is a physician who graduated from Rowan School of Osteopathic Medicine and completed training in internal medicine, neuropathology, and integrative medicine. She has a son with a severe epilepsy, neuropathy, autism, and intellectual delay. As a champion of integrative care, she serves on the task force for Rowan Integrated Special Needs Center in South Jersey, as well as the Health and Safety Subcommittee for the New Jersey Council on Developmental Disabilities. Also, she is our Council 7 member that represents Camden and Burlington counties. So we also have Melanie Ayers, who's a registered nurse and has been for 28 years. She holds a master's degree in nursing leadership. She has a varied experience in hospital, in hospital nursing, hospice, and school nursing. She's nationally certified as a school nurse and was responsible for coordinating care for students in the school setting, including those with complex medical needs. Melanie currently is an assistant professor at the College of Health Professions at Wilmington University. She is completing doctoral studies in nursing practice that'll focus on physical fitness of adults with intellectual disabilities to improve their health outcomes. Melanie's proudest accomplishment is being a mother, especially to a wonderfully inspiring 23-year-old young lady named Emma, who has Down syndrome. So also we have Margaret Hefferle. Margaret started her nursing career in pediatric surgery at Columbia Presbyterian, where she worked running a surgical floor for 6 years. She got involved in the disabilities field while working for SPAN, which is the statewide parent advocacy network. After some time off to raise their 2 boys, one who has autism, Margaret has been a nurse case manager at Special Health Services for the last 11 years, where she speaks daily to families who have a child with special needs, and a majority of them have disabilities ages 3 to 21. And we also have Jennifer Airy, and Jennifer is a mother of 2 boys with special needs and a social worker at Rowan Integrated Special Needs Risen Center, where she assists families with advocacy, locating resources, and parent education, as well as therapeutic counseling and caregiver support. Jen also serves as the chair of the Developmental Disabilities Subcommittee at the Camden County Children's Interagency Coordinating Council, or KIAC, and is on the board of several local nonprofits. So we're pleased to announce all of our speakers, and I think that it's really great that they're in our community and assisting parents throughout the state and just trying to support each other. So for today, the purpose of this is just to discuss a roadmap for health and wellness. So I'd like to introduce Andie as our first speaker.
Thanks, Eileen. Thank you so much. Everyone, welcome. It is my honor to be with you this morning. And as Eileen mentioned, I'm a physician and I'm a mom. and I have a special needs son who has enriched my life in ways I never imagined 30 years ago when I decided to enter this amazing territory of being a mom. So have you ever experienced something like this? You need, I'm just going to share my screen so you can see my slides as well. So let me just pause for that. Okay. Have you ever experienced something where you know that you need services for your child with special needs, intellectual, developmental disabilities? You know, kind of like this slide, the background of this slide, you know something's out there, but it's very nebulous. You don't know exactly how to access it, but you feel like it's there. And that's kind of how I was. So I'm a physician, and it was really a wake-up call for me to be a physician and, number one, not be able to help my own child in ways that would heal him and make him get better. That was really a tough pill to swallow. But number two, to be a physician and kind of feel very helpless and not know how to access the resources that he needed. And so that's where integrated care is such a wonderful resource for all of us. So what exactly is integrated care? So it's not to be confused with integrative care. So integrative care is using holistic and alternative modalities or treatments to bring into the healthcare plan. That's not what we're talking about today. What we're talking about today is integrated care. And integrated care is a team approach, which is oftentimes wonderfully refreshing when it comes to the healthcare of our children. We've got a very complex system. We're very fortunate that we live in this country and that we have access to so many resources for our kids. However, it's really complex and it can become overwhelming. And so this integrated care approach helps us to navigate the complex system that we're faced with today. What's wonderful about one of the things that's wonderful about the integrated care approach is that there's a core team, and at the center of that core team is you, the caregiver, and the client or patient. And I'm going to interchange the words client, patient, and our children, because our children are the patients, they are the clients in this model. And the caregivers are us, the parents or the guardians who are actually the ones taking care of these special needs kids or special needs adults. So we are at the heart of that core team. Without us, there is no team. So we are the center of that. And then primary care practitioners are also on that team, as well as behavioral and mental health practitioners. And then, as Jen Airy will tell you later, social workers who are invaluable in this team approach. So this is a big slide. This slide is really the crux of what I'm going to be talking to you about over the next 10 minutes or so. So with the integrated care model, there are key components, and I call them the 4 C's because in my mind, that's how I think about them. I think the 4 C's are cooperation, collaboration, continuity, and being community-based. And we'll talk about each one of those a little bit. So let's first talk about cooperation. What's wonderful about the cooperative nature of integrated care is that the needs of the clients, the needs of our kids, are placed first above all else. You know, a lot of times medicine has placed the needs of the system before the needs of the patients. And that's not what an integrated care model is all about. So it puts our needs first, but it also includes cooperation between specialists. You know, maybe your child sees a cardiologist or a neurologist. So it's a cooperative, we see a lot of cooperation between these specialists along with our primary care provider. It also includes dentists, therapists, speech therapy, occupational therapy, physical therapy, just to name a few, as well as other members of the entire care team, whether it's physical health, mental health, behavioral health, social health. Now let's talk about collaboration. Collaboration is different from cooperation. They're similar, but different. And what collaboration is providers communicating about a diagnosis or a treatment. How many times have you gone to see a doctor and you spend a whole bunch of time going through your laundry list of the surgeries your child has had, or the other specialists that your child has seen, the testing that they've had done, the medications they've been on, the symptoms that they've been having. And then that provider decides that maybe they can't help you. And so they send you to another provider. And then you have to go through the whole laundry list all over again. Wouldn't it be great if providers could kind of pick up the phone, call each other, or have interdisciplinary team meetings where they could communicate directly to each other about a diagnosis or a treatment? So that's what I mean when I say collaboration, is the providers really coming together to discuss things and brainstorm together. The next part of the model, the third C, is continuity. And this is continuity of care, continuity of providers. You know, we want our kids to have the same provider each time they go see a doctor or a practitioner or a specialist, because it's hard to develop some type of rapport when you're seeing a different person every time you go in. And for our kids, especially, even more than typical children, for our children, this is important, because if they have one bad experience, then it might be years before we can get them into another doctor's office or a medical office without having a huge fight on our hands. So if they can see the same provider each time, develop a rapport, understand that this is a safe place, make it an experience that is pleasurable for them, as pleasurable as it could possibly be, then that's what the continuity part really embraces and embodies. And it's also continuity when it comes to the medical record. So, you know, right now in our country, EMR, electronic medical records, are really the standard of care, but not all offices have the same electronic medical record. So you may have had a bunch of testing done, seen a bunch of specialists within one health system, but then when you go to another health system to see another specialist, they don't have any of your information. And so that continuity of care isn't present. So continuity of care is really important when it comes to the integrated care model. And then the fourth C is community-based. You know, what we do not want to happen is for our children to end up in an urgent care, in an emergency room, in a hospital, because they haven't been getting the care that they need. And then we are being reactive and trying to get them the services that they need. No, what the integrated care model is about is having a community-based, proactive type of care management. And that can be in the office, or it could even include home visits. So we want to, at all costs, keep our children out of the ER or the hospital. We want to keep everything community-based as much as possible. And then on the right side of this slide is, I want to talk about the emphases that the integrated care model places. And so really, what this model aims to do is to treat the whole person. And if things evolve in a favorable fashion, it's not only treating the whole person with regard to our children, but also with us as their parents, their caregivers, and their guardians. So wouldn't it be wonderful if you could take your child to a primary care office or an integrated care office where they get their care and they're comfortable in that office because they're familiar with it. But then if you, as their caregiver, need care, you can go to that office as well. How wonderful would it be if you didn't have to find someone to take care of your child while you go get your care? You can bring your child along with you and know that they're going to be comfortable in that setting as well while you get the care that you need. So it's really focusing on treatment of the whole person when it comes to the special needs client as well as the caregiver. It takes an approach to overall well-being. It looks at the whole mind-body connection, mental health, behavioral health, physical health, and as I mentioned before, social wellness also, because all of these things contribute to the experience that we have as human beings on this earth. And if we can have a nice balance of all of them, if we've got wellness in all of these respects, then we're going to have wonderful overall well-being. Again, not only for our kids, but for us. Let's face it, if the caregiver isn't well and the caregiver isn't taking care of themselves or isn't getting the care that they need, it's going to be really difficult for them to take good care of the child or the special needs family member. And so we look at creating a sense of overall well-being for our kids and for ourselves. And that really looks at preventative care as a big component of this model. So with preventative care, what we're looking to achieve is healthier clients, healthier caregivers, less urgent care visits, less emergency room visits, less hospitalizations. We really want to use this model to help improve the client experience or the patient experience. You know, again, I talked about repeating the same story over and over every time you go to another specialist. Well, imagine if you could go to a specialist and they could say, oh, I see here in your medical record that you've had these surgeries. These have been the challenges. Your primary care doctor communicated with me. These are the challenges you've been having. Let's address those. How wonderful would it be if they've got a little bit of information about your background before you even get there? So that, of course, would improve the experience that we have. It's hard to keep our kids in these offices when we go to all these medical appointments. So if we could streamline the appointments as much as possible and communicate ahead of time, that's such a wonderful opportunity for our experiences to be improved. And then a lot of times, you know, the complexity of the system, as I mentioned earlier, is so difficult to navigate, it's overwhelming. And so this model with the collaboration, the cooperation, the continuity of care is designed to help navigate the complexity of that system with assistance from the team. And lastly, you know, we want our kids and we want our families as a whole to have access to providers who care. You know, pediatricians are trained in part to know how to handle someone who's nonverbal. They're trained to take care of infants and young children who may not be able to verbally communicate. And so they have this knack for being able to understand better nonverbal communication than physicians who specialize or practitioners who specialize in taking care of adults, of typical adults. But what happens when our kids start aging out of the pediatric system? You know, we're in Southern New Jersey. We've been getting our son's care until recently at Children's Hospital Philadelphia. Well, the closer he got to being 20, 21 years old, the closer we got to not only aging out of the school system and losing that stability that we'd had for all of those years, but we were also aging out of the healthcare system. So we felt like the rug was being pulled out from under us. We felt like we were falling off a cliff. And then we were being thrown into these physicians' offices that take care of typical adults. They didn't have sensory-friendly waiting rooms. They didn't understand when my son was speaking loudly in the waiting room that that's okay. You know, they didn't know how to handle that. And so wouldn't it be wonderful if we had access to providers who care about our population, they're interested in improving the experience of our population, they have sensory-friendly offices, they actually are engaged in interested in having shared decision-making. How many times have you gone to a doctor's office and they'll say, so this is what I think the diagnosis is, and the treatment I'm recommending is this, period. And you're not really given an opportunity to collaborate with that practitioner. What integrated care aims to do is to have shared decision-making, where the practitioner might say to you, this is what I think the diagnosis is, after talking with your primary care doctor and talking with the therapist and communicating with the other specialists. This is what we think the diagnosis is. And let's talk about treatment options. You know, you could have option A, option B, or option C. I think option C might work best for you, but let's talk about the other options. Do you want to talk about options? And then there's a question mark at the end of that, rather than them telling you the one thing that they think would be best with a period at the end. They leave an open-ended question so you can discuss different options that might be better than the one that they would prefer. You know your children better than anyone else. And so it's important that we have shared decision-making, that our kids and us as parents and caregivers have decision-making powers as part of that team model. And, all of these lead to better client satisfaction. And ultimately, as I noted at the bottom of the slide, the goal for all of us is improved quality of life. The goal for the medical team and the mental health team and the team as a whole is to improve the quality of life for us. And that's our goal for us and our kids. And so through all of these methods, we can improve quality of life for us and our families. And, this is really gaining traction. This integrated care model is gaining traction. When the government starts putting money into something, that you're getting buy-in and they're starting to support that. So CMS, which is the Center for Medicare and Medicaid Services, back in 2019, decided they were going to start embracing this model, and they were going to start some pilot programs in 7 different states. Fortunately for us, New Jersey is one of those states that was chosen. Most of the states that were chosen are on the East Coast, except for Oregon. And then there's Ohio and Illinois in the middle of the country. But New York, New Jersey, Connecticut, and North Carolina are the other states. So they decided they were going to give $126 million over 7 years. It wasn't just one big lump sum. It's over 7 years, starting in early 2020. Now, COVID put a glitch in that plan a little bit. Well, a lot, for a model called the INC model, INCK. And what that stands for is Integrated Care for Kids. And what this model, this pilot program is going to do is service clients age birth up to 20 years old. And it's going to incorporate an integrated care type of model. For New Jersey, our portion of that $126 million is $15.8 million over 7 years. So it's, $15.8 million seems like a lot, but when you divvy it up over 7 years, it's a little over $2 million a year. It's not a ton of money, but you know what? It's something. And so what this tells me is the government is starting to buy into this type of program. And it's my hope that as over the next couple of years, we'll see that the people who are getting access to care, who are getting access to resources, are doing well. And so that's going to then create further funding in the future. So unfortunately, it only goes up to age 20. So if your child is like mine and they've aged out of that system, they could be a little bit stuck. But again, I'm hoping that this will gain traction and we'll see this expand into the adult special needs population as well. So that is the conclusion of my presentation. I thank you all for your attention. There's going to be an opportunity for you to ask questions in the Q&A chat box, and then we will answer those at the end of the session. Thanks so much. I appreciate your time.
Hi, everyone. Thank you, Andie, for that wonderful presentation. I'm sure it's going to help a lot of people. And just to reiterate, please put your questions in the Q&A, and we will be addressing them as we go on. And there'll be plenty of time left at the end of the presentation for questions for our speakers. So next we're going to be focusing on the importance of health and wellness, and we have Melanie Ayers and Margaret Hefferle with their presentations. Melanie, again, Council 8 member, Gloucester, Cumberland, and Salem, and we welcome Melanie. I think we're having technical difficulties. Oh,
yeah, it was blocking me from trying to share. And actually, Margaret is going to start. I'm going to share this.
Oh, okay.
But I'm going to be flipping slides, so I just want to make sure.
Okay, Margaret. Margaret is from Council 1. She's our chair from Council 1, representing Morris, Sussex, and Warren. Go ahead, Margaret. Welcome.
Sorry, I didn't know that I could undo my video, but I did. Okay, so I am Margaret Hefferle. I have a son with autism who's age 30. And in my brief bio, I had mentioned that I'm a case manager at Special Child Health Services. So on a daily basis, I speak to families who have a child with a special medical need. And the vast majority of my caseload is children or young adults, because we go up through the 21st year with intellectual and developmental disabilities. So when I was asked to do this presentation, my first thought was, we all know what we should be doing. Eat right, eat nutritious foods, eat healthy foods, decrease calories, increase exercise. But the challenge is, how do we do it, not only for ourselves, but encourage our children to do it? I know that, our kids can be particularly stubborn. So that's an added challenge. And, the one thing is just so important is to start early, to try to get them to eat a wide variety of foods. And because it's a little harder to deal with later, and just, try not to make it a fight, because it's one that you might lose. Okay, so sorry, next slide. So I'm gonna identify some of the challenges. Now, all our kids are individuals. So when I mention, things about children with autism and Down syndrome, which are, pretty large percentages, it may or may not apply to your child. But at the end of the, and I think I met decreased expectations. I'm not a nutrition expert, but you are the expert on your child. So, these are strategies and things like that that you'll have to carry out. So, so that is a concern. So one thing that's interesting is children with autism, feeding and eating challenges are huge. It's something that I would say the majority of families that I deal with every day. So it could be, sensory issues impacting them, the smell, the taste, the texture of foods. There oftentimes need for sameness, and new foods kind of bringing on anxiety. Children with Down syndrome are affected as well. Lots of times it could be early on with the anatomical differences that they may have, the shape of their mouth and palate, and physiological differences through function. They may have low muscle tone, poor suck, and are at risk for choking or aspiration. So those are some things that, have to be dealt with early on. Okay, so, talking about the extremely restricted food habits. I work with families who have had situations where their child is down to eating only 2 foods. And it's really a concern. I know a lot of kids have issues with soft foods, that they may have an aversion to that. So they really are, prefer crunchy foods, won't eat yogurt or things like that. And actually kids that, it's a part of them when they look at it. I've seen kids gag. And so, one thing is to go slow with some of those things, because, those aversions can really get, really stuck. And I've had a lot of families that, with the opposite, is that they can't leave the baby food, that they're going to school and that's what they're eating. They're still using a bottle and even a pacifier. And, the earlier you try to address those things appropriately, the better off you are, because, if they get cemented in there, it's really hard to deal with later. Okay, next slide. Oh, sorry, I'm so sorry, back. Also don't, so hypersensitivities, we already talked a little bit about, that the sense of smell, the look of food, The color, I mean, I know lots of times, you know, for typical kids, you know, going to the bagel store and they have green bagels or those rainbow bagels is a great thing. A lot of times our kids really like the predictability of things and they like things to look a certain way. So changes really need to be small and slow. Sometimes schools try to do feeding programs and, you know, without a lot of professional help, that can sometimes create difficulties because, you know, I have experience with a family that they were doing a feeding program early on and offering foods and insisting that a child, you know, have a certain food. I think in this case, it was macaroni and cheese. And they, you know, gave it to him, he took it, whatever. He wound up after school, after the after school program, coming home, and he still had that macaroni and cheese tucked in his cheek. And even though he's expanded his food choices, still will not eat any kind of pasta. There are a lot of OCD type eating patterns. I mean, I think, you know, a lot of us have them. You know, it could be that you eat certain things first, or that you, you know, eat one food item and then go on to the next and the next. And so, you know, sometimes with our kids, we have to think like, how important is it? You know, does it impact them? Does it make that you can't, you know, go out to eat dinner? Because, you know, sometimes, you know, changing things. I know somebody else, a young boy, used to make his peanut butter and jelly sandwich at school, using it in little containers, and the school decided that that was a little too OCD, so they wanted it made and sent in, and that child never ate peanut butter and jelly again. You know, it's certainly kids may have anxiety. It's actually a neophobia, an extreme or irrational fear or dislike with anything new or unfamiliar. Sometimes our kids, you know, have a hard time making sense of the world, particularly kids who don't have language or understand language very well. So, you know, when you really mix it up for them too fast, it's anxiety provoking. And, you know, kids in general, particularly as they age, again, kids with autism often have anxiety. And so, you know, that would be one thing to see if, you know, that might need treatment, you know, so that's something to talk to your doctor about. But, you know, it's pretty, a rule of thumb is, you know, offering choices, going slowly, a sniff of a new food, a lick, a bite, or even just being near the food might indicate progress. And then, you know, with those hypersensitivities, you know, whether they prefer the softer foods, you might start to increase texture just a little bit at a time. Or, you know, if they're into the crunchy foods, you know, maybe you can find some of those veggie chips or ways to get more healthy food choices in slowly, so that you relieve some of that anxiety. Next slide. Another issue is chronic overeating or compulsive eating. I mean, if you've been home during this pandemic, you know, with nothing to do, that's certainly been an issue for a lot of us. Sometimes it could be an inability to sense when full. A lot of kids have, you know, very different sensory issues. And, you know, sometimes there's kids who don't get the signals from the body that they might otherwise. And so they don't always know when it is they have to go to the bathroom until it's extreme emergency. And also, you know, not being able to know when they're full right away. You know, eating as a soothing sensory behavior, you know, rewarding yourself with food. Who doesn't do that sometimes? But, you know, the challenge is to try to not make those, you know, really strict habits. Using food as a reward. Early on with the principles of applied behavioral analysis with autism, a primary reinforcer was almost always food. So, you know, kind of moving away from that. using food as a reward rather than, good food and nutritional choices are important. So, some of the things that are helpful is, portion control, a lot of the Weight Watchers tips that they use, smaller plate, smaller portions, drinking a lot of water between meals or even before meals. Sometimes with that, I often, after I eat a meal, feel like having something sweet. And if for some reason that's delayed or there isn't anything available, 15 minutes, that feeling is gone. So perhaps, right after a meal, a distraction to a preferred activity or an active activity, to kind of wait for that feeling, for it to hit bottom, to feel that fullness, rather than, just to keep going. And then, already mentioned emotional eating, after a tough day, or, I deserve this type of thing, or eating out of boredom. I mean, Melanie's going to talk about activity and things like that. So, hopefully a lot of us can maybe get rid of some of the COVID-19 pounds that we may have gained over this pandemic. Next slide. Sorry, can you go back one? Did we miss one? I'm sorry, I missed it. Sorry. The impact of medications. So a lot of our kids, they're not immune to co-occurring mental health diagnoses. And in fact, some of them, it's more likely that they might have something like that, even though it's really hard to tease out. I mean, that's a challenge in the medical community. Just really saying, it's not a behavior, but it might be something new and, a mood disorder or something like that. But the challenge is that those medications can have a tendency to cause weight gain. Sometimes it's that they increase appetite, and that's a challenge. So, one of the things that's important to do is to take data. I know it like you have nothing else to do, but when you're starting a medication, it's really important to see the effects of it. And, you're just not going to, on a day-to-day basis, you're not always going to know what those are. So, weighing somebody might be important. Also looking at other changes. I keep a calendar, and I kind of write, when it's a bad time or a bad night. And it's really important because, the tough times seem really tough and they seem to last forever. But if you look at the data that you've taken, sometimes it's not as bad as it seemed. And the easy times seem so brief. And so it's only by sort of looking at that data, and working with your child's doctor that you would get an idea of the reality. Perhaps it's not as bad as you thought, or the other thing is you start to see patterns. So that's important too. Also with medications, I deal with families a lot who, aren't really comfortable, whether it's ADHD medication, which actually has its own side effects. Oftentimes it's weight loss and poor sleep. And so really working with your child's doctor, medications in this case are a little more of an art than a science. But one of the challenges is that families sometimes aren't comfortable. So, they keep saying, we don't want to use medications. And, obviously it's a decision between the family and the doctor. That data is going to help you to identify whether it's needed, but then also, you don't want to short circuit the process. You don't want to try something and you have, one bad night and then you say, oh, no, we can't do this. We have to stop that, even though, that medication perhaps, is purported to start working in a few weeks. So that's, again, where data is going to help you to identify the side effects of medications. And then it's just, it's just really important to look at the data, work with the doctor, find the right medicine that seems to have, the best effects with the least side effects. Next slide. GI issues are a big factor with our children. I'm a nurse. I could talk about poop all day, but I won't. But chronic constipation is a real issue for our kids. And, at Special Child Health Services, I'm based, in fact, I'm here right now at Atlantic Health System at Gorriab Children's Hospital. And our whole team, oops, I'm sorry, my thing just went, sorry, gotta put my password in. So sorry. So we have a whole team of GI specialists, and they're quite familiar with our special needs populations because they really do need the help. So, the chronic constipation is a serious problem, and sometimes it requires treatment at a hospital. So that's another time where data takes place. You really want to know, keeping track, how many days has it been? It's uncomfortable. So it really will affect child in every area in school. So, working with a gastroenterologist is important to develop a bowel regimen. Obviously, dietary things, increasing fluids, increasing exercise are really important but over time, in the bowel, more fluids are taken away. And so that's where you're going to get more hard stools and chronic constipation. And, it can be a really big issue with our kids, particularly in the autism population. Often they're using Miralax, prune juice, that increasing fluids, increasing activity, also, creating a schedule for time to go to the bathroom. That's important. You can kind of look for clues to see when they're having a lot of gas or whatnot, and then really try to make sure there's a schedule and a habit to make things easier. A lot of our kids on the whole other side of the spectrum, bowel inflammation, diarrhea, it's a real issue. And so you really have to kind of try to tease out why that's happening. Gluten sensitivity, it's a high incidence in the Down syndrome population. It might be food allergies or food intolerance, lactose intolerance. So all those things, working with your gastroenterologist.
Now, that's your job for the next 2 hours, Mr.
Oops.
Really? Oh, God.
Eileen, you should probably mute yourself.
Oh, I'm so sorry.
No worries. So
I didn't.
Ruling out, the food intolerance, allergies or things like that. And then, making dietary changes to avoid problem foods. Also, gastroesophageal reflux is a big thing in our kids, particularly if they're overweight. So, there are risk factors or overweight, so it could be important to maintain an upright position after eating, sleeping. You can actually lift the head of the bed a bit. It's important, medications, again, working with your doctor, avoiding certain foods that are more acidic. The last thing on the slide is withholding. Now, that's typically refusing to have a bowel movement. That's typically a developmental stage that happens in toddlerhood to a lot of kids. They may think it might be fear of the toilet flushing. It might have been via a painful experience. It might be, they used to say, a loss of a body part, but a lot of times it's based, for whatever the reason, an anxiety and control. And it's a real problem for a lot of my families, even much later in, when they're older. And, it's really important to deal with something like that early, because it only gets worse over time, or gets more difficult or more ingrained. So, once again, you're increasing fluids, increasing activity. A lot of times they're using Miralax, mineral oil. I don't know about you, but my kid was like a detective, and could find anything I tried to put into something else. So I was so blessed when he could swallow pills. Next slide.
Mhm.
So strategies. You know, a referral, you know, working with the gastroenterologist. I know here they have nutritionists on staff and they often make the referral, but you can make that request so that, you know, they can help work on these things, you know, setting up a menu, you know, working within the parameters of your kids' food choices and stubbornness, setting up routines, eating at the table. You know, obviously everything is earlier, dealing with it earlier on rather than later. But, you know, I have a lot of kids who don't want to eat at the table. You know, certain strategies that anybody could use, you know, sneaking in vegetables, perhaps in pureed and baking them in things, you know, certainly multivitamins, supplements, keeping foods in rotation. That is one of the challenges that my families have. And I have myself, I have to say, I've been working from home part-time and working in the office, and just got a little easier to do takeout. And, you know, we want to support our restaurants and things, but, you know, I made something that chicken cutlets that my son hadn't seen in a while. And I was accused of serving him poisoned chicken. So, you know, oftentimes, even if they just at a certain point eat certain foods, keeping them in rotation, because if they haven't seen something for a while, they may look at it as though they've never seen it before. So that's another challenge. Do I have next slide? So there are practitioners out there to help you. You know, whether it's oral, motor, or swallowing issues, there are specialty speech therapists, speech language pathologists that deal with oral motor issues, whether it's physical or, you know, and some are called feeding therapists that they can help with that. We have a, you know, flowing business here at Atlantic Health. Also, you know, particularly, I mean, probably all our kids, you know, it's always suggested with kids with autism, you know, a behaviorist being involved, you know, kind of making that slow progress. We have, a program here, and they're starting to, oh, I'm sorry, I just want to go back with the feeding program. So, you know, we have a smaller one, but there are some hospitals that have very large feeding programs. In our neck of the woods, we're in the north here, St. Joseph's has one that combines a multidisciplinary team that helps with some of these issues. So that's medical staff, speech therapists, psychologists, and board certified behavior analysts working together using the principles of ABA. And they've had a lot of success. It's a, you know, it's an outpatient program, but it's a daily thing. And so for if things get really difficult, that's something that families can, you know, access. So just in conclusion, you know, we're trying to improve their diet, avoid the real minefields, take data. It's so important because you go to that doctor's office and they say, oh, when was his last bowel movement? Or, you know, what number of foods they eat? You know, you're going to have that information right at hand, and seek help. You know, there are programs and strategies out there to help families. You know, it's not easy, but you know, there is help out there. So Melanie's going to be up next and deal with another easy topic, which is fitness. So thanks so much for being here today.
Thank you, Margaret. And here's on the last couple of slides on Margaret's portion, there's a ton of resources to look into some of these nutritional aspects and some strategies. So I'm going to talk about fitness. So I'm Melanie Ayers. Thank you everyone for joining us on this Saturday morning. And I know, like in my own personal world, when the day have program shut down, my daughter's program shut down for about 3 weeks when the pandemic started, she did nothing. It was sitting on the couch watching TV day after day, and I'm trying to work. It was a really tough balance, but I just realized how important fitness is to her and to many of our children. So I'm going to bring in some background, a little bit of research. So current research shows that obesity is 2 to 3 times more prevalent in those with IDD. And like Margaret stated, a lot of this can be caused by medications because they may cause weight gain. But another one of the big factors, just like in my daughter's case, is that a lot of people with IDD, it's very common for them to live a sedentary lifestyle. One study showed that people with IDD reported having over 7 hours of sitting per day. And this lack of physical activity is a huge contributing factor to poor health outcomes. So I'm going to go over some of these health outcomes, the contributing factors, and the benefits of fitness, as well as some strategies to help get this population more active. So sedentary lifestyles, or being inactive, leads to multimorbidity, and that means having more than one health condition. One study showed that there were over 900 adults in this study, and 2/3 of them, or 67%, were obese or overweight. And over 61% had 2 or more health conditions. And as they got older, like older than 60 years old, the prevalence increased to almost 73%. And also they found that the more profound the disability, they were found to be even more sedentary and at a greater risk for multimorbidity. And you can see here on the slide that the most common conditions include diabetes, hypertension, which is high blood pressure, and cardiovascular disease, so that's heart disease. And the healthcare costs associated with a lack of physical activity for all causes, not just the disabled, are $117 billion nationally. And if the IDD population is very sedentary, well, they are definitely contributing to these costs. So some of the factors related to sedentary lifestyle include a lack of motivation and an acceptance of a sedentary lifestyle. If most individuals with IDD are not pushed into doing physical activities, they aren't going to do them on their own. This population tends to be happy not moving. So these individuals, and many times their families and caregivers, they just accept this lifestyle and they don't help them to become more active. Other issues include having difficulties being independent, and also their parents worry about their existing medical conditions. They don't want to exacerbate these medical or physical conditions and cause them any kind of harm. And also those with IDD who live alone need more motivation and support to be physically active. They won't get moving on their own. Now, with regard to lack of caregiver support, one issue was that the parents felt like the paid caregiving staff should be responsible to support the individual with physical activity. And conversely, the staff felt it was the parents' responsibility. So in this case, no one took responsibility in getting these individuals active. And parents also didn't recognize that their own engagement in physical activity was important. And it was a way to role model for their children. So the research shows that family support and role modeling is very important to this population's physical activity. And of course, it's widely known that transportation is a huge barrier, along with limited access to appropriate health promotion programs. If they can't get transportation to programming, and if programming is lacking, how is this population supposed to find opportunities to be physically active? Some studies have found facilities like group homes and other congregate living settings, they blame the fact that they had limited financial resources and that they are continually understaffed. And these were the reasons why they cut activities from their budgets in these settings. And also there's a lack of training that leads many gyms to not cater to the needs of those with IDD. And therefore, there's a lack of programs in many communities to serve this population. But there are so many benefits to being physically active, especially in the IDD population. One study found that when those with IDD were physically active, these individuals had the perspective that their health was better. If they weren't active, they viewed their health as not so good. So from their viewpoint, being active equaled better health. And another benefit is better survival rates. Another study looked at the survival rates for older adults with IDD, and they showed that there were better 5-year survival rates for those over 50 years old if they had better fitness levels at the beginning of the study. And having better health outcomes were evidenced by having a decreased risk for multimorbidity with conditions like heart disease and colon cancer and type 2 diabetes and bone density issues because they were physically active. Most of us when it comes to cost savings on the system, we really don't recognize or care about the cost when it comes to medical care for our loved ones. We just want them to get the care that's appropriate for them. However, this overburdened health system could be eased if we can promote better health outcomes using physical activity as one strategy. Not only is there a cost savings on the system, but there's also possibly less time spent in the doctor's office, less medication that may be required, and less tests that may be uncomfortable for our family members if we can decrease their health risks. So health promotion and physical activity may make individuals feel an enhanced quality of life. And Andie talked about quality of life, and that's what, that's what we want for our children. And we make them, by having a better quality of life, having better physical activity and good health promotion, it makes them feel more empowered by they're able to make their own healthy choices to improve their health outcomes. Additionally, physical activity is also very important for mental health, especially in these times. Being physically active helps to expend that pent-up energy, which may help alleviate some anxiety. It boosts the brain chemicals like serotonin and dopamine, which can help bolster better moods and help alleviate depression. And exercise raises endorphins, and you've all heard of runner's high, right? So being physically active makes you feel good physically and emotionally. Being isolated and stuck in the house for over a year now has taken its toll on everyone. And honestly, not only those with IDD can benefit from physical activity, but we can all benefit from physical activity to improve our mental and emotional health. So why not try an activity with your family member with IDD? It would help them, it would help you. So it's a win-win, right? So this leads into strategies to get this population moving. So looking at person-centered care, we have to find what interests them. If someone with IDD doesn't like walking on a treadmill, then it's going to be difficult to get them to do that. So we have to ask questions like, do you like to be outside? Do you like to go to the gym? Do you like to swim? Do you like dancing? How can you incorporate their interest into physical activity? Many studies found that including music and games as motivators are effective strategies. So people with IDD may become more engaged and find that activity more fun. Music and games may hold their interest and make them want to do the activity again. So physical activity doesn't always have to be super structured. Like my daughter, and I do too, we love to dance. So I'll turn on the music and we'll dance around the house for a few songs, or she'll turn on her Wii and pop in the Just Dance discs and we'll do a few songs while we're like competing against each other. And we definitely get a good workout, and it's something that we find really fun. So sometimes we have to be creative and try new things to find out what works best for these individuals. And keeping it interesting, and we have to keep it enjoyable, and we need to plan person-centered physical activities around the individual's interest. There are some studies that found that having a buddy or mentoring program where you'd have somebody with IDD would buddy up with a person who doesn't have IDD. So the person without IDD tends to be a role model and will motivate them to do fun activities, and they do them together. And this was found to be effective because the individual didn't have to do the activity alone. And when it comes to exercise, using combination strategies like interval training is great. So using strengthening and aerobic exercise combined seem to be more effective than just one type of exercise alone. So walking or running is great, but adding in some strength training may be even more beneficial to health outcomes. And the studies found that most people with IDD can do these activities safely and without hurting themselves. And another strategy is to include health promotion and education along with physical activity. So this can be more effective because they learn why activity is important to their health, and it should include some nutrition education and when to go to the doctor and some other self-care information that focuses on health promotion and prevention. And this information should be shared not only with the individual, but also with the family, because sometimes families don't really know what is proper nutrition or what appropriate exercise is. I mean, 2/3 of the general population is either overweight or obese. So this education can help everyone in the family, which in turn will help support the individual with intellectual and developmental disabilities. And as far as training for like trainers, personal trainers that are at the gym. One study used a trainer who had a level 1 Special Olympics training for their exercise sessions. So this may be something that you may want to talk to the personal trainers at the local gym that they could explore. So maybe they'll become more comfortable working with this population. And this training may then lead to more availability of community programs. And that SO coaching resources that's in red, that's the Special Olympics coaching resources. That's a link to the website that informs you on how to become a Special Olympics coach. So it has all the details there. And finally, now more than ever, we need virtual programming. I know Zoom isn't for everyone, and I know people are like zoomed out, but for those who can use virtual platforms, this can be an effective way to bring physical fitness programming to the individual instead of the individual trying to seek out these limited opportunities in the community. So virtual programming also overcomes that transportation barrier because they have the program come to them in their home. They can do group sessions, so they can socialize too. For example, I'm right now running a program showing videos of yoga combined with Bollywood dancing over Zoom for young adults with intellectual disabilities. It's fun. They are loving it. They're able to do some more of the intermediate yoga poses, or they modify the poses to the best of their ability, you know, to whatever they can do. They love the dancing to upbeat music. They have a whole choreography that they're learning. They're using dance scarves to make it fun. It's been great. And the small groups are socializing before and after the sessions. So they look forward to it. They're having fun while they're moving. Again, we have to be creative and try new things and see what works for each individual. So in closing, the CDC recommends 150 minutes of moderate to vigorous activity per week. And that breaks down to 30 minutes, 5 days a week, a half hour, 5 days a week. So those with disabilities, they are still encouraged to do physical activity to the best of their ability. The studies show that most people with IDD, they can participate in physical activity if they get the opportunity, if they get the support, and if they get the motivation to do so. So we have to be their advocates to help get the appropriate activities available to them. And so this next slide has my references. And thank you so much for your time and your attention today.
Thank you, Melanie. That was just such a positive and upbeat presentation. And I think we all could benefit by it. Just even doing it, as you're saying, you're doing it with your daughter, doing it along with our loved ones, and just we all need to get moving during this time for sure. And thanks so much, Margaret, as well. So next up, we have Jennifer Airy, and she is going to be focusing on how to build an integrated care network. I was having technical difficulties. So yes, so Jennifer, if you would like to take it away.
Absolutely. There we go. Unfortunately, I had to change my location here just a few seconds ago.
Oh my goodness.
I'm at the Stratford COVID clinic site.
Oh,
Where
wow.
we're having a special event today for individuals with intellectual and developmental disabilities to get their shots. So I'm kind of multitasking.
That's great.
So I appreciate everybody's patience with me. But I was very excited by this opportunity when I was first approached to talk about building your care network, because I don't think we really talk about that very much. And families are really left to kind of figure it out on their own. It brings to mind, I have 2 sons with autism, and it was actually my youngest son who was diagnosed first. And I remember being in the doctor's office and getting the diagnosis and looking at the doctor and going, "What's next?" And she looked at me and she said, "I don't know." And that really, really struck me as wrong. Because if you think back to when you have your child and they're a tiny baby and you're leaving the hospital, I had a trash bag full of stuff, of resources and coupons and samples and all kinds of stuff that they sent me home with, and pamphlets from doctors' offices and lactation consultants. And I go home with something that's equally life-changing with nothing. And my doctor couldn't even help me. And that was really hard to take. So as a parent, as I'm sure all of you can relate to as a caregiver, that we have to be resourceful. And we have to kind of figure things out as we go. And so I want to talk a little bit about that. And depending on where you are sort of in your journey, it kind of depends on what resources you've identified. So I'm going to go ahead and share my screen here. And there we go. Okay. So for me, I'm going to talk about how to build your integrated team, and I'm coming at it from a social work approach, which means that when we're talking about people, we're talking not just about people in isolation. We're talking about people as they exist in their community and in their family and in their environment, and how all of those things interact together and to make them who they are. So when you start looking at somebody or looking at yourself and you're saying, how do I build my network? You want to start by looking at, what do you need? What's your most important need? And you kind of want to solve that one first. And so a great way, falling again back on the social work model, is what is your hierarchy of needs? Of course, number one, you want to make sure that you're safe. And if your family's in crisis. So if you're not safe, if you are in crisis, absolutely call 911, go to the emergency room, contact mobile response. Those are all really important and great resources for you. Of course, mileage can vary sometimes depending on our crisis and our experiences with who we might get on the other end of the phone or coming out to the house. But for the most part, when the systems are working, they work really, really well and can really help and get you the supports that you need. So Perform Care, if you do call mobile response, is the one for individuals under the age of 21. That's part of the Children's System of Care here for the state of New Jersey. It's completely free. It is not income-based. They'll come out to your house, they'll do a needs assessment and help connect you to resources in the community. And then the CARES program, they also will come out and meet you where you are and do a needs assessment and kind of go from there. Another great resource that I think a lot of people don't know about is 211. So if you need help with food assistance, you need help with housing, different things like that, kind of getting your basic needs met, calling 211 anywhere in the state of New Jersey will help connect you to social services within your county. And that's a great way to kind of get that ball rolling, to get you connected to whatever programs might be available to you. And they will also connect you to services for people with IDD. I've had people report to me that they've called 211 and been connected to autism support groups, which is really a positive thing that, in my opinion, and I was really impressed to hear. So I'm really glad to see New Jersey is moving in those directions and making sure those services are available to families, however they might access them. So the next slide here is, once all those sort of basic needs are met, you have a little bit of space to kind of sit back and look at, where are the gaps? Where are the holes that need to be filled? Do you have gaps in healthcare? Are you looking for that right doctor? Are you looking for a dentist that does maybe sedation or has that right approach? Maybe your dentist, isn't very kind, or doesn't have a good approach with your child. Maybe you're having problems with education. Maybe you need an advocate to help you. Maybe you're looking for somebody to help you with financial planning for, will and a trust. You need an elder law attorney for that. Maybe you need help with finding social skills groups, peer groups. Your child might need some social groups to help them make friends. That's probably one of the biggest needs that most families kind of come to me asking for, is help to find those social opportunities. So spiritual, a lot of times individuals have really difficult experiences when they go to church or to their synagogue or their temple, and they have individuals who give them looks or stare at them or make them feel very uncomfortable for just being who they are. If they might have a behavior, or maybe they're a little too loud or a little too, have too much movement or get up too much, they can be made to feel unwelcome, which is really unfortunate. And then respite, that's another big request, is helping find support staff for families to have the help that they need. And kind of the list goes on. And so where do you go to start filling those holes? So to do that, there's some tools that you can use. And I love Charting the Life course. I just wanted to kind of touch on this really quickly. It's something that's really gained a lot of momentum here in New Jersey as this wonderful resource. And I've seen a lot of wonderful classes and workshops and things like that out there. So if you just, the council's had some, Bog Center's had some, there's a bunch of different places that have been using Charting the Life course and the Life course tools. But it's a way of looking at an individual with a disability and doing person-centered planning. And that means not having a generic one-size-fits-all plan or solution. You're really looking at the individual and finding their unique strengths, their unique needs, their unique capabilities, their unique challenges, and identify where the opportunities are. So using Charting the Life course really helps you identify natural resources in the community, and natural resources even within individuals in your family, individuals you connect with naturally already, and then helps you see where the gaps really are. So you might sit down and go, oh my gosh, I really need help finding a communication device for my child. And when you sit down and actually start using a tool like this, you realize, oh yeah, their computer teacher at school was telling me about something that they had experience with for another student. Or maybe you could be talking to somebody at your church and they could say, oh, well, we used something for somebody else in the congregation. You never know where those opportunities are, and once you start writing them down and charting them out, you can really help you kind of chart a map and learn to know where those resources are and where you might need to kind of fill some of those gaps. And so kind of going into a little bit more specific, like where some of those needs might be that we talked about earlier, and where some of those resources might exist. So for like parent groups and peer support. So as caregivers, it's really tough because we feel a lot of isolation. It can feel very lonely to be a parent and to be a caregiver. You can feel like you're on an island and that there's nobody else around you. I'm sure we've all been there. I've been there at that PTA meeting when they're all talking about how, they need to have the dance scheduled, or they need to have, soccer practice, and they have to take their kids to theater group drama club tryouts. And you're sitting there and you're going, that's not my life. I'd like it to be my life, but that's not me. I don't fit in with these parents. And it can feel really lonely and really isolating. And so it's really hard. So it's important to connect with other parents and find those opportunities. Because once you do that, they can in turn, once you connect to other parents, they can in turn point you to other resources. Because there's one thing that I have learned in all my years of being a parent and being a social worker, is there is nothing like a fellow parent of a special needs child or a caregiver for resources. We are thrilled once we find somebody who is awesome. Like if you've got that dentist, if you have that ABA company, if you have that, PT company or that writing therapy company, whatever that resource might be, we are thrilled to be able to like shout it from the rooftops, because we want other parents to have the same amazing experience that we have had, because we know what it's like when you have those bad experiences, and we want to try to help other parents to avoid those pitfalls. So definitely connecting with other parents is so helpful. So really, the great opportunities to connect with parents are in like some of the parent support groups, like Mom to Mom. That's a statewide support group, your county FSOs. So if your loved one with a disability is under the age of 21, you don't have to be active with CMO, with Perform Care, to still go to the support groups and use services at the Family Support Organization. So you can still go there, get information, attend trainings, do all kinds of stuff there, even if your child is not active with Perform Care. So that's a great resource there to connect with other parents, and you can ask questions and get resources that way. And if your child's still in school, your county, your school district should have a special education parent advisory group or advisory council, the CPAC or CPAG. And that's another great resource. Another thing that I can't even stress enough is online support. There are a ton of Facebook groups where families, parents get on there and ask questions, and I swear within like 5 minutes sometimes there's 20 answers. So if somebody says, hey, does anybody know in Bergen County if there's a good podiatrist? And there'll be 20 responses by the end of the day. It's amazing. And not only do you get that live back and forth interaction with other parents, but you can also search on past questions that parents have asked. So you never know what you'll be able to find out. And there's a whole wealth of information. So I encourage families to always go online to some of the Facebook groups and just dive in and, just post your questions. Become active, become involved, and just give it a try. Granted, sometimes you're always going to get a bad seed here and there, but really these groups are, for the most part, patrolled really well. The moderators are really good, the admins are really good in these groups, and are really careful to make sure that they cultivate a very supporting environment. So I highly encourage you to get involved, because these are really wonderful resources. Another opportunity, if you're looking for resources and ways to connect with others, is at workshops and special needs events. So you're going to meet other professionals in the field. So it's a great way to meet others. So if you're looking for that elder law attorney to help you with that trust, or that school law attorney to help you with the sticky situation you have with the school district, or if you have questions about therapy dogs, or whatever the workshop might be on, it gives you a chance to get to know a professional who's talking about the subject and kind of audition them and see, oh, they really do know what they're talking about, and kind of gives you a chance to sort of start to build trust and see if they really are somebody you'd like to work with. Some of these events could include some of the events you might be able to go to network with parents might include some school functions, fundraisers, special needs events like if there's any kind of like an autism walk or a fundraiser for cerebral palsy or Down syndrome events. There's all kinds of like an awareness days. March is full of awareness days. There's Rock Your Socks is this month. All different kinds of things that are being done in the community to raise awareness, and just getting involved is a great way to meet other parents, get to know other people, and ask those questions and start to build your network. Also, I advise people to just get on those mailing lists. So the New Jersey Council for Developmental Disabilities would be one I would hope everybody's on the list for, as well as many other nonprofits here in the state would be really, really great resources. And then in the community itself, always keep your ears open and your eyes open, because you never know. You could be in the line at the grocery store and you could be, behind somebody who's a fellow special needs parent. and you could overhear something, or you could see, you know, another kiddo that you identify with, and you know, and a parent that you identify with, and you're like, oh my gosh, that's a fellow parent. I'm just going to go over there and say hi. And some other places might be at your doctor's office. It could be, you know, at your place of worship. Talk to your existing service providers. If you have a therapist that comes into your home, you have lots of time to talk. So if you have if you have a therapist in your home, ask them, say, you know, you see other providers, you talk to other parents. Do you know of anybody who does this service? Do you know of anybody who provides this particular thing that I'm looking for? And talk to the other parents at your child's school, or talk to their teacher. And a lot of times programs, I've seen day programs, and of course, children's classrooms will sometimes release, ask permission, of course, to release lists of participants' phone numbers and contact information in case people want to get together outside of the program, or maybe get together for birthday parties, or whatever might be happening. And so, of course, that's another opportunity to build those social groups, meet other caregivers and parents, and start to build that network for yourself. And of course, connecting with other social workers and finding those people whose job it is, just like me, to help facilitate those conversations and help connect you with those resources, especially when you're in the beginning of your journey or during those transition years, when it's really hard to try to learn a whole new system, and you're facing that cliff that happens when you're looking at, you know, adult services. So here in New Jersey, there's Special Child Health Services, which I personally feel it does not get the recognition that it deserves. It's an amazing service. So if your loved one is under the age of 21, each county has a Special Child Health Services unit that helps connect you to resources. Highly recommend reaching out to them. Their services are free. Perform Care is also a great resource, again, for under the age of 21. And then your support coordinator or support broker with DDD. Once you're connected with DDD, they help you find resources. And especially if your support coordinator has been with their agency for a number of years, they have a bunch of other clients. And so there you're going to know of other programs that their other clients are involved with. And they'll have heard from, you know, just talking to their coworkers in the office and doing their own research that can be incredibly helpful. If you have a really good support coordinator, they're invaluable. And then the good thing is that if your support coordinator isn't very helpful and you find that they don't return your calls and you're not getting the level of help that you need from them, you can always change your support coordinator. I always like to remind families that you can do that every 30 days. So definitely keep that in mind. If you're not happy with the level of service that you're getting, you can certainly do that until you find somebody that you're really meshing well with. And that's everything for me.
Thanks so much, Jennifer. I mean, just wonderful, wonderful ideas, and just really a creative presentation. We appreciate it. And I just want to thank all of our speakers for their wonderful tips. And I know that we have also some tips that were sent in from our members, and that we will share later. So at this point, we have question and answer Q&A. We do have some. I would invite all to pick it up in terms of if they have a comment. Some of the questions in the chat have already been answered. We can go over a few of those if we have time as well. So I have a question here. My healthcare insurance has great autism services for my young daughter. For my adult daughter. I hesitate to put her in an independent apartment with the DDD voucher because I'm concerned that if I do that, I won't be able to claim her as a dependent, and therefore she won't be on my insurance any further. Does anyone have a comment to that question? Okay. Well, I mean, I'm not an expert, but I feel that even if you are in a group home or a supervised apartment, if you're the person's guardian, that they could still stay on your insurance. That I believe to be true. Does anybody else have any other input in terms of that?
Eileen, I would agree with you. That's my gut feeling, but I hesitated to answer because I don't know that for sure. And I didn't want to give any misinformation.
Right, yeah. I mean, yeah, because there's different levels of guardianship. I know that if you have full guardianship, that's in my personal case. He is forever a child, so therefore he could be on ours forever. Most people can only stay on until they're 20, I think it's 26, right? Okay, I hope that answered the
So
question.
Eileen, I would just add is that if your insurance is through your job, I would talk to human resources at your job to find out about your policy. If it's through your union, again, through your union rep, or just call the insurance company and ask them what coverage they have, because you are entitled to, you can cover a child up to 26, you're required unless they have their own insurance. But otherwise, you really should talk to your own insurance company about covering it, because you might have the coverage all the way through, and you could ask about your benefits and what they will cover and how they will cover things. So.
Okay. Thanks, Gabrielle and Andie. All right. So we have a question from Bonnie. For families who are enrolled in family care, how accessible is integrated care from knowledgeable physicians, especially specialists, social workers, dentists, and et cetera? Because I guess the concept is new. So how accessible would it be? I guess family care would be Medicaid, straight Medicaid, right?
So, and Jen, you may want to weigh in on this also. So in our experience, now we live down in South Jersey, so we have access to the Risen Center, the Rowan Integrated Special Needs Center, which is absolutely amazing. They accept our insurance. We have full access to all their services, their specialists, et cetera. So at least down in South Jersey, we don't have a difficult time at all in obtaining access to services. With regard to North Jersey, I'm less familiar with that realm just because of my geographic distance from North Jersey. Jen, do you know anything about opportunities for care in North Jersey?
I'm not as familiar, just like you. I do know the ARC was running some integrated sort of care. I believe now. I'm sorry. Let me rephrase that. I think the ARC was running some similar type program, but I think that's no longer being done. One of the county ARCs was doing that, but beyond that, I am not familiar with what is happening in the other parts of the state.
One thing that you could do is call your insurance company and ask for a care manager. And then, lots of times they can look up what the policy provides, who are the in-network providers, and perhaps there might be, some indication through what they have.
Yeah, and again, that's doing a lot of research that can sometimes be a little cumbersome, because if you're looking for all providers who take Medicaid within like a 3-county area, you could potentially be looking at a very long list, especially in the more densely populated counties. So I would recommend maybe reaching out to some of the resources in your counties that might help you make those connections. That I covered a really great resource up in North Jersey too. In addition to like the ARCs and and then the Facebook groups and places like that, there's Metro West, which is one of the Jewish federations. That's the one up in North Jersey, and then there's the Jewish Federation in South Jersey. And South Jersey has the Jewish Abilities Alliance, where they have a social worker who will connect you for free to resources in the community. They'll act like a navigator for you. And I believe North Jersey will do that to an extent as well. So there's definitely resources within the communities that you could tap into to kind of do some of that legwork for you, instead of necessarily, like calling potentially, dozens and dozens of doctors' offices just to ask them if they do integrated care.
Right. So also Bev Roberts from the ARC is really a wonderful resource. And we've had her on several of our regional kind of outreaches for folks. She is just the Medicaid whiz in terms of connecting people. And, I would also say in North Jersey, there's, I think, the Dawn Center for Independent Living. They are a resource for folks, I think, in North Jersey as well. And, but it is one thing I would say as a parent, like just trying to navigate the Medicaid system, and you'll get a list. And as you were talking about, Jennifer, parents just have to call because they don't ever update their list, if doctors are being pulled off. So it's definitely challenging so that's why it's great to just have an integrated care hub. That's what we would love to see.
Yeah, and you'll find too, a lot of times that those lists aren't updated. They could have somebody that moved away 2 years ago and they're still on that list.
Yeah.
And they're totally outdated.
Yeah, it's been, you're talking about building a network. You try to build a network just of your medical for your child, and then they pull out, and it's just, also I think it's challenging for parents of adult children as well, because I just don't think it's the support and services are as available. So that's another thing that we definitely
I would agree. I think probably it's safe to say that at the Risen Center, probably 95% of our referrals are word of mouth to other parents, referring other parents.
Yeah. That's why our family support planning councils have such a wonderful role within this. So, and we're trying to expand it to children's as well. So, okay, let me just see. Does anybody else have any further comments on this wonderful discussion?
Just with the care managers, everybody who has a developmental disability, particularly that were switched over to the managed care associations, have assigned case managers that are strictly DD case managers. So they know a little more than your average, cold call. And if you're assigned one, and if you're getting, the personal preference program, it's the same nurse that comes out and does the assessment. It may differ between the different HMOs, but so it's not just a cold call where they're going to email you a list. They deal with a lot of families, and clearly, like anything, the longer they've been doing it, the more they've learned and the more they know.
Right. I think
Eileen,
yes.
scanning through things within our chat. Bev Roberts joined us this morning. So
Bev, thank you.
She wants everybody to know that the ARC has a fact sheet on how to have the parents' health insurance continue for a young adult with IDD. Like we said, talk to your HR department before your child turns 26. There's a form to be filled in, and the doctor has to certify it. The young adult has to be incapable of self-sustaining employment. So I guess that's what the doctor is certifying. So you can contact, get the information from the ARC of New Jersey, arcnj.org, or you can email Bev. She's very generously said email her, as she usually does, broberts@arcnj.org. So anybody have those questions about continuing insurance, reach out to the ARC.
Thank you
They're
so
a
much.
wonderful resource.
Yes, that is great. Okay, we also had a comment regarding our prior question. If your child has a disability, they are permitted to be on your private insurance ongoing, and that's Zinke McGeady shared that with us, past the age of 26. So that is for sure a rule. And we're seeing other comments on this, that you definitely can still continue to take them as a dependent on your taxes, even if they're not living with you, I think is the thought. Okay, so we have a comment from Yolanda Smith, who is our chair for Council 7. I'm finding that even if you have full guardianship and have covered your adult child on your company's group insurance, if you start a new job and your child is over 26, the new company will not provide coverage for that adult child. They have said since you didn't work for them when your child was under 26. So that's a very interesting kind of caveat there. Is that even allowed? Is it like at the employer's discretion? That might be another question for Bev.
It could be a question for Bev. I'm not sure, because that's not the area that I'm familiar with. But you should go through the HR manual, and as well as, like you said, Bev might have the answers through her worksheet about whether or not coverage can continue from one company to another company, because I'm not quite sure about the state regulations on that. So I'm not really sure of how to answer Yolanda on it.
Okay, well, that's a good, that's really an issue for folks. I mean.
No, I realize it's an issue for people. I just, it's not an area that I'm familiar with.
Okay, so we
Yeah.
need to further research that one.
Yeah, it can get even more complicated if the employer is based outside of New Jersey, and so the insurance is based outside of New Jersey, and they're not necessarily subject to New Jersey regulations.
Wow.
We run into that a lot with ABA, providing ABA services. So a lot of families who have kiddos under 21 and are trying to get ABA therapy, and their families work for a company that's based outside of New Jersey, a lot of times their ABA therapy is not covered, even though New Jersey mandates that it be covered. That's their loophole to not have to cover it. So it's really problematic. So insurance is incredibly complex, and there's a lot of variables.
I was going to say the other one is if it's a self-funded program, they also don't have to cover ABA.
Exactly.
And then if you're on, if you have dual insurances and Medicaid doesn't want to, if it's not a Medicaid provider, and say I have my insurance that's not Medicaid, and I take my son to that doctor, then whatever is not covered is not going to be picked up with Medicaid, because it needs to be a Medicaid provider, which is just really complicated.
Yes.
Also,
Medicaid is the payer of last resort. They will pick up if you stay within network, which is a problem. Again, nobody likes reading that big thick book that you get about what your benefits are, but that's the rule book. So you really should look at that. Talk to, again, your human resources or your case manager or your insurance company directly about what your coverage is. They usually send out that book at the beginning of the year, and it gets kind of stuffed someplace because you're not really looking at it. But that would have exactly what your policy rules are. And you really need to look at that to find out how to maximize your benefits that way, and what your rights are and what you can do for appeals. So there's I guess there's a question that could be for
Gabrielle, hang on one second. Just based on that, if the doctor accepts both your private insurance and your Medicaid, and then the fee that the private insurance paid is more than the usual or customary fee that the Medicaid pays, actually the doctor has to eat, you wouldn't necessarily have to pay that. The doctor has to absorb that cost.
wow.
Which is why a lot of them don't accept Medicaid.
Wow. Okay. The nuances.
yeah.
There's a question about I think eating.
Yeah.
Yeah.
At the top.
As long as you're on. Any thoughts about people who eat extremely fast and barely chew their food?
My screen closed up again, but oftentimes behavioral techniques can help. I know with my own son, I say, take a breath, put down the fork, whether you're, gonna count number of chews, like you can say, okay, you have to, chew 10 times, whether you, almost like with washing your hands and singing happy birthday, that maybe you could, develop like a thing to sing or something like that. I mean, it's not easy, but it's what you can negotiate.
Yeah, also, I mean, I have a little bit of it, not being a nurse, but my son does have eating and swallowing issues, and he did attend St. Joe's Eating and Swallowing Food Clinic, and we just brought him back again because he's having, it was great when he was little, but now he's 29 and he's having issues. So they are open to all, I just want to say, and that would be in Essex County, St. Joe's and Patterson. So they really, they really do have a wonderful eating and swallowing clinic. I was advised to kind of just have him eat and then have every 2 bites or so, have him take a little sip of a drink, but that's just him. So, that might not work for everyone, and just be patient, I would have to say, because you're not going to be doing it fast with your child if he's got eating and swallowing concerns, for sure. So just thought I'd add a little something there. Okay. Okay, so I have full guardianship. My daughter is 32 and lives with me. Oh gosh, where did that go? Okay. In my home, and long-term care is what my employer says. If apartment with supports is an apartment with supports considered long-term care? Anybody have any?
I would think not. I mean,
insight?
I say no.
Yeah, I agree. Because it's not, to me, long-term care is more of a medical facility, whereas an independent apartment setting is not medical based. Does that make sense?
It's a specific term, long-term care. And I think, Andie, you're right, that it's a term that includes medical benefits. Usually you think long-term care, you're thinking of like nursing homes. Is that correct?
Yep, exactly.
Yeah, and I think Kyoko, did you have a comment on this question?
No.
No, you did not. Okay. I thought I read you would like to answer. Okay, sorry about that, Kyoko. All right, let me see here. Okay. Okay, so this is a question based on just our integrated care, I would have to say. Where do I go to complain about PPL, public partners, I guess public partnerships, not paying my provider for services that are already approved in my plan? So it's frustrating that travel is paid but not services. So I guess that's a twofold question there. So does anybody have a comment on that?
I would say if you haven't reached out, you should have a point person who you have a meeting with, well, virtual meeting in this day and age, every 3 months on a quarterly basis. And so I would reach out to that person as a starting point. If you already have, then there should have been a packet that you got when the program was initiated that has a list of resources should you need them. So that's what I personally would do if I had the same type of issue. That's where I would be.
That is, yeah, because I know especially during this pandemic time, it's been really, really frustrating, trying to get and reach PPL. And, the good news is we advocating for getting parents to be parents paid for watching their children during this time. But, just really hard to get through to anybody. So I guess perseverance with that for sure, with PPL. And also you can, Diane Flynn at DDD is really great. If you can't get anywhere, I would absolutely, if it's an SDE issue, that she could be helpful with that as well if you can't get through to PPL.
And I'm looking at the Q&A, and a bunch of our fellow council members popped on with advice, and most of it is ask your support coordinator to escalate the issue. Each support coordinator is assigned a DDD specialist. On the other side of it, PPL has a high touch specialist to support all support coordinators. So and I guess that's saying the same thing. Go to your support coordinator, let them know what the issue is, ask them to help you escalate it, and see, and try to resolve it that way. So there's an email that's here that you could go to, all right? ces-njppp@pcgus.com. And you can email that. But I would start off with your support coordinator, that they're the person there that when you have a problem about your DDD services, you really should reach out to them for support and advice on how to solve things. I think we're through our questions, Eileen.
Oh, sorry, I was on mute. I think so. This has just been really great. I'm enjoying the formatting. I think the webinar format is really good with this. And I think we have it being recorded so that people can check it out later. And I think that's all really great. So I just wanted to, I don't think I did my spiel at the beginning about family support planning councils, and please join us. And we have a Facebook page and you can see all the happenings, and I would encourage everybody, because we are all members and we all support each other. And we're looking really forward to meeting back down in Hamilton at some point for things. But I appreciate you all and all the time you're spending and all of the wisdom you're imparting to our members. And so Gabrielle, I'd like to introduce Gabrielle, our wonderful vice chair, who's going to do the closing comments.
I'm a member of Council 1, Morris, Sussex, and Warren with Margaret. So I wanted to thank all our panelists for joining us today, Dr. Andie and Melanie and Margaret and Jennifer, as well as our wonderful tech support, where Eileen and I would be absolutely lost without, Kyoko Coco and Rebecca Novemsky, as well as all of you for joining us on this lovely spring morning. I think we finally hit spring, fingers crossed. I want to let people know that there's many events and happenings coming up in the next few weeks. On March 18th, there's going to be a caregiver listening sessions hosted by New Jersey Caregivers Task Force. On March 23rd, the Disability Rights of New Jersey, DRNJ, and its DD Partners Network is hosting a town hall listening session about COVID 1 year later. Just again, information for everybody. DDD has created a employment and transition to 21 help desk, which is going to focus on secondary school students and their families. And for our under 21 crowd, a bill is working its way through the New Jersey Senate process, which will allow students who are turning 21 and aging out of their district to use the IEP process to stay in the district to receive services. It doesn't mean you have to repeat high school. It doesn't mean you have to repeat the grade again, but to receive those services without having to go through appeals and the litigation process. That right now just got out of a Senate committee for education. I believe it's before the Budget Appropriations Committee, and then it's got to go to the Assembly. Also, the Coalition for the Direct Support Providers is asking for help with the fiscal year 2022 budget to support paying our workers. They do a wonderful job. They help us tremendously, and for them to get the pay that they deserve. All of this you can get through the different sources on our website. I would suggest starting off with the New Jersey Council of Developmental Disabilities website at njcdd.org, njcdd.org. And from there, you can click on links about these events, as well as finding information out about us, the Regional Family Support Planning Council. As Eileen said, we're 10 councils throughout the state of New Jersey. And we hold forums like this. We have meetings, and we do outreaches. Well, pre-COVID, we did outreaches, and we still hope to go back to those. But the council is your opportunity, you or your loved one, to have a voice in the services that are out there, to network with other people, to get the ideas that Jennifer was talking about, that all our panelists were talking about. The network that you build, the community that you build is invaluable. And the Family Support Planning Network Council is there to help you find those resources. So again, thank you so much, everybody, for joining us. Remember to set your clocks ahead. Daylight saving time starts tomorrow. We lose an hour of sleep. But thank you. And we hope to see you at our next forum, which would be May or June. Eileen and I and the rest of the council are working on that. So enjoy the rest of your day. It's beautiful and sunny out. Thank you.
Thanks, everyone.